Good morning. Good morning, good afternoon, good evening, ladies and gentlemen. I'm Paola Barbarino, the CEO of ADI, and it's my pleasure to welcome you in the second of the series of webinar on the World Alzheimer Report this year. I remind you the World Alzheimer Report of 2022 was Innovations in Post-Diagnostic Support, the changing role of clinician, treatment and care intervention is the actual subject of the webinar you're listening to today. Next slide, please. As ever, before I introduce you my wonderful fellow panelists, we are going to do a quick poll to check who is with us today. And whilst we are doing that, I remind you that we have a translation in 25 languages available in artificial intelligence mode. So if you follow the instructions that are appearing in the chat line, they will come with you. So the poll is at the moment asking you what is your background. If you could fill that, that would be great. So we have an idea of who you are. So I hope you've had a minute to join the poll. And now these are the results of the poll. So the vast majority of you are researchers and medical professionals, with some educator, some government representative, family and formal carer, quite a few people from industry. And I cannot see the poll myself. There we go. And volunteers of Alzheimer's Association. Thank you for coming. As ever, I will remind you that it's possible to introduce yourself in the chat line. Please do and let us know who you are. In the Q&A instead, please put any question that you have around the webinar. As ever, we have a very fast-paced webinar, and we will try and answer as many questions as possible. Now, a few words about ADI, who we are. We were established in 1984. We are the umbrella organization of 105 Alzheimer and Dementia Associations around the world. We represent you all at the WHO, at the UN, OECD, and other global and regional bodies. We are the creator and promoter of World Alzheimer's Day and World Alzheimer's Month, and the publisher of the World Alzheimer Report and other reports. Our vision is prevention, care and inclusion today whilst we are waiting for a cure. And today we have to speak about the World Alzheimer Report. But before we do that, we ask you to engage with us on social media. There's a lot of social media you can join to follow what ADI is doing. And remember, all of our publications are available for free from our website. A quick thank to our sponsors, as you can see them here on the slide. And then if we can move on, just to remind you that we are a charity and that you are very welcome to make donation. I have to thank a lot of you have been sending us donation in the last 2 months. I presume as a consequence of World Alzheimer's Day, I cannot thank you enough. Everything that you give us is very helpful. I've also had a number of requests for sponsoring us through marathons, Ironman, and of course, a lot of you already are doing it for birthdays and for Christmas. Please continue to do that. It's very helpful. But remember, we are a very small charity with a very small staff base, so we are not able to support you through this fundraising effort. So if you can do them from your end and then send us a check, that is the lovely way to do that and to keep our admin costs low so that we can really focus on getting our job done and try to change the life of people living with dementia and their families at all the possible level that we can. Next slide, please. Now, a few welcome and introduction to our speaker. We have here with us an incredible roster of speakers, and I will tell you a little bit more about them when I introduce them one by one. But just suffice to say that Pedro Rosa-Neto from McGill will be with us, as Professor José Morais as well from McGill. They are two of the co-authors of the report. Birgitta Martensson, who is the former CEO of Alzheimer Switzerland, is living with Alzheimer, will represent people living with Alzheimer. Dr. Grazia Dell'Agnello and Susan Dr Santi represent respectively Eli Lilly and Eisai, with interesting points around diagnoses, and Dr. Yuda Turana, who is also part of the medical panel of our member Eisai in Indonesia, will be telling us about their view of this. Just to remind you some of the big figures that ADI always talks about: the global impact of dementia. Every 3 seconds, someone in the world develops dementia. The disease is bound to be costing to society $2.8 trillion, a sum of money so big that it's always difficult for me to envisage it, by 2030, and there are currently 55 million people estimated to live with dementia, and presumably at least 200 million people impacted as families, and that number is going to rise to 139 million by 2050, and dementia prevalence and incidence is growing all the time, unfortunately. Now, just to remind you that these webinars and our World Alzheimer Report are often in the context of the Global Dementia Action Plan. And just to remind you of the Global Dementia Action Plan, which of course was underwritten by all the nations that pertain to the WHO in 2017, has 7 areas, and this report is focusing on dementia, diagnosis, treatment, care, and support area. That was both the report of 2021, which was on diagnosis, and the report this year, which was on post-diagnostic support. Just to give you some of the top line finding, 85% of people living with dementia are not accessing post-diagnosis support. That's globally. I repeat, 85% of people living with dementia are not accessing post-diagnostic support. They don't even know that it's there. Next slide, please. 2 in 3 people living with dementia said they did not have a personalized care plan. This was in our survey for the report. 54% of carers felt stressed often or all of the time while trying to cope with their caring responsibility. Globally, 58% of people living with dementia say they did not have access to a key worker or navigator after their diagnosis. In the report, we introduced this concept of navigators. You will hear more from Pedro and José. As a person that should be able to help someone with a diagnosis navigate the complex world of post-diagnostic support. Next slide, please. More statistics, 45% of people living with dementia in low and middle income countries say they were not offered support following their diagnosis. 2 in 3 carers from low and middle income countries say those they cared for had not been given access to post-diagnostic support, and 37% of people living with dementia in high-income countries say they were offered nothing following their diagnosis. This is the stark reality we're looking at. Next slide, please. So, recommendation of the report. There are quite a few. National dementia plans need to become a policy priority. Person-centered care must become the norm. Care should be culturally appropriate. It should be gender inclusive. Support for carers must be prioritized. In the report, there are a lot of really impactful essays on what happens to carer after a diagnosis. Care needs to be coordinated and accessible. In red are the topics of recommendations that are relevant to this workshop, to this webinar. We must continue to challenge stigma and raise awareness because it remains a severe barrier. Education must be improved and expanded, especially of healthcare workforce. Further trials of cost-effective and evidence-based psychosocial interventions are needed. We'll talk about that more today. And risk reduction must be bolstered. Next slide, please. And it's with great pleasure that now I'm going to hand over the floor to Professor Pedro Rosa-Neto, who is one of the co-lead authors of the World Alzheimer Report 2022 from McGill University. Now, as ever, our webinars are fast-paced, so all speakers will speak one after the other. Then we'll hand over the floor to you for questions. Please post your questions in the Q&A and introduce yourself in the chat. Thank you so much. Pedro, the floor is yours.
Thank you so much for the very kind introduction. As you posed very well, this report is extremely important for various reasons. Dementia has no cure, and the prescription of care consists in several measures centered on the patient, on the care partner, and also in the family and communities. So can you go to the next slide, please? So what's important, I think, here in this presentation is to highlight some aspects of innovation in this report. And we'll start with the chapter 1 that explains that one should take care into consideration a simple but efficient staging system in a mild, moderate, and severe dementia. The World Alzheimer Report also highlights the pre-dementia clinical stages of the disease, the recognition of the earliest phases, neurocognitive conditions, is critical for the efficient implementation of therapies capable to mitigate Alzheimer's disease pathophysiology that are coming up, and also other measures that focus on non-pharmacological interventions. So for patients, the earliest the diagnosis posed and the more efficient the measures to maintain the well-being, it is important to mitigate the rate of progression of clinical symptoms and to minimize the risks associated with the cognitive, motoric, and behavioral consequences of dementia. The prescription of care, including pharmacological and non-pharmacological interventions, is highly dependent on the stage of the disease. So the next slide, please. So this slide refers to the chapter 4 that highlights the impact of the siblings and their preoccupation of obtaining or acquiring Alzheimer's disease in the future. So this highlights an importance and the progress in the genetics in terms of guiding these individuals and to clarify their possible exposure or their possible risk to develop dementia in the future. And this is extremely important because today we have not only, we have genetic information available through direct consumer genetic testing. And I think the healthcare professionals must be able to handle this counseling in face of the availability of this information. But it's very important to properly guide families in relationship to their risk to develop Alzheimer's disease. And this is certainly an important development in terms of management of these patients and families. Next, please. So this refers still to the chapter 1 and shows the impact, the economical impact on the different stages of the disease. And you can clearly see here that individuals in the advanced stages of the disease, the cost of this management of these patients is much higher as compared to individuals at the very early stages of the disease. Next slide, please. So in the chapter 15, discuss the progress in terms of multi-domain interventions. So the multi-domain interventions refers to combined non-pharmacological approaches, focusing physical, mental, and nutrition health as the basis of prevention. The combination approach intends to maximize health and mitigate the reduction of risk, mitigate risk factors for dementia development. Next one. So this is one of the most exciting chapters showing progress in the field, and they try to highlight the prospects of having new pharmacological interventions targeting the toxins that are leading to neurodegeneration and to dementia. So this chapter summarized the progress in the field and try to indicate that in the near future, if these new therapies prove to be effective, that there will be a lot of hope, and this has to be properly scaled, take into consideration geographic, genetic, and economic diversity across the globe. Next, please. So the chapter 19 is, I think, is one of the most fundamental because talks about personalized prescription of care. So it highlights the fact that there are several dementias that are atypical, and they involve a significant amount of non-cognitive symptoms, such as behavioral symptoms, motoric symptoms, and that needs to be managed in the personalized form. So this chapter is huge, and it's very detailed, and what serves as a guide to general practitioners and also healthcare providers and is written actually in such a way that the general public can understand the concept of personalized in care in the various different contexts. Next slide, please. The chapter 23 somehow involves this generalization of the principle of personalized medicine in various different contexts, and take into consideration initiatives around the world that are willing to promote health and to mitigate risk factors for developing dementia. And here I finish my part of the report, and I'm going to pass the word to José Morais.
Thank you so much, Pedro, for this bird's eye view of what is a huge part of the report. The report is over 450 pages. Part of the reason to do these webinars is to make sure that you can have a tour d'horizon and then hopefully delve into the report, which is freely available on our website. Can I please ask everybody, I've seen some comments on the chat line, which are very welcome. Can you please put questions you might have for Professor Rosa-Neto in the Q&A box? And with that, I hand over the floor to Professor José Morais, another co-leader of the report from McGill University, which will be looking at a different aspect of the report. José, the floor is yours.
Thank you, Paola. Good morning, good afternoon, good evening, depending where you are in the world. I'm very pleased to be here. And I will tackle this presentation with some summary of a few chapters that I was a leader or a co-leader. This particular chapter 6 was dedicated to post-diagnostic support in primary care. And we all know how stressful can be primary care because of lack of resources and also infrastructure. But I want to start this presentation in a positive note by saying that there is different models of care that can be used in primary care setting. And this excerpt here tells us that successful case management models are associated with smaller caseloads, regular appointments with people living with dementia and their carers, and education about the disease, as well as proactive and timely follow-ups. So good practice in primary setting, primary care, can facilitate a successful management of patients or persons living with dementia and their carers. And this is good news. We know that the right approach to treat the disease and support the carers needs to be a holistic one, integrating continuing care in the context of a declining function and increasing needs of family, because unfortunately the disease do progress as curative treatments is not available yet. And it is recognized that through a multidisciplinary approach, we can succeed in providing better care. And for that, we need to synchronize all the healthcare providers involved in the care with good communication amongst them. Next. And an essential part, which is an emphasis of this report on education, is that a more global approach aimed at reducing the impact of dementia diagnosis for clinicians is early education about chronic diseases. And frankly, dementia is one of the, I would say, flagships of chronic diseases. And this education should start in medical school, including primary and secondary prevention measures. Next slide. On chapter 9, it was dedicated to late stage of dementia. We separated dementia into its early, moderate, and late stage. And late stage is very challenging because the person is losing many of his capacities, especially in activities of daily living. And the choice of treatments, assistants needs to be defined ahead of time when the person is still capable of participating in the decision-making about care. This is why we surveyed people living with dementia as well as their carers to identify if there has been a discussion about end-of-life and advanced care planning when we reach a late stage dementia. And not surprisingly, because we are aware of how the situation is, about 50 to 60% of people have not done any advanced care planning. You know, and this is a pertinent point, since management of late stage dementia should take into account person's level of comfort, well-being, and prevent undue interventions, because in late stage, doing certain investigations and intervention can make it more difficult rather than providing comfort and quality of care. So for these reasons, we put an emphasis in late stage dementia to manifest person's choices and the way they would like interventions to be made. This is it for chapter 9. Next slide, please. Chapter 16 was dedicated to intervention for the carers, mainly education. Carers have a very important role, not only on day-to-day basis in assisting persons living with dementia, but also as their advocates. And I quoting here one of the statements that I found very humane, which is, carers are the keepers of dignity and personhood for people living with dementia. And in busy clinical settings, including acute hospitals, we tend to forget these very basic but important considerations, because it's a very fast turning situations. Now, when those who are caring for are sometimes treated as an illness rather than an old person, this contributes to increase the strain of carers. And we know that carers, you know, have feelings of powerlessness, high levels of stress, and role conflicting among family members are commonly experienced by informal carers. One way of helping them is through education and knowing also how to navigate the healthcare system. Now, again, one of the very efficient ways of empowering carers is through psychoeducation interventions that encompasses a tailored person-centered approach. And this needs to be addressed in appropriate education activities. Next, please. Finally, chapter 24 is a kind of summary of our understanding of what should be done in order to deliver patient-centered care. Our overall impression is that there should be efforts to improve education and professional development for clinicians and other health and long-term care professionals in post-diagnostic management and support. And then we went into an effort to summarize what should be, you know, the items that should be worked so that we would achieve this global understanding and reach treatment conditions that are the most positive and effective. And there is 18 of them. I will not go through all of them, obviously, because of lack of time, but this can be found in the report in the last chapter. And we have to deal through education and appropriate care with points such as disease management, carer support, continuous professional development activities. And we would need the help of different organizations and follow the recommendations that comes from very comprehensive programs that exist already. I will finish here and will be available to answer questions on the appropriate time. Thank you.
Thank you very much, José. We are running a little bit late, so can I remind all the speakers to look at their timer so that we try and keep in time and leave some time for the questions. And can I remind everybody to post the questions in the Q&A? Thank you so much. A lot of people from Scotland today. Thank you. And we all know that you have done a lot in post-diagnostic support, so it's great to see so many of you here with us. And now I hand the floor to Birgitta Martensson. Birgitta Martensson is the former CEO of Alzheimer Switzerland, and she is a former board member of Alzheimer's Disease International. She is now living with an Alzheimer's diagnosis herself, and very kindly has agreed to speak on behalf of people living with dementia. We are having some issues with her video, so it may come in and out of video, but she is here with us in voice. Birgitta, you will need to unmute yourself, and the floor is yours. Thank you.
Thank you, Paola. Yes, I think it's better you just watch my photo. There's nothing much to see anyway. It's an honor to be on this panel. I'm speaking as a person with dementia. By the way, I just got back from seeing the doctor for my regular visit, and I had also a scan made of my head. What I feel is absolute crucial is that the person with dementia should have a more central place in taking decisions for the future life. We do talk a lot about carers, which is, of course, extremely important, but I think it's just as important that we integrate people with dementia in the discussion, which means early diagnosis, because if we don't have a diagnosis or if it's made late, then of course it's difficult to participate. So that would be the claims that I have to society. Early diagnosis, which also means that we must dare to talk to the doctor when we feel that we have memory problems, and physicians should be more aware of what it is, the first signs of memory problems. Most of them aren't aware because they haven't experienced it. So I think that's the point where we have to try to get physicians to learn more about dementia, meet people with early stage dementia, to really understand what it's all about. And then the life that comes after you have a diagnosis is, of course, to have the right treatment. Well, so far, treatments are not really reputed to be very efficient. Hopefully, there will be others that will come on the market. I hope so, really. I take 2 of them today, donepezil and memantine, which normally you're not supposed to do, but I do that and get along with it. I don't know if it makes me any better, but it's very interesting to be using all the possible treatments that are around for this disease. I live on my own, and I managed to take care of my life on my own, doing my payments and so on. The problems I have today are mainly orientation problems. finding my way, not the where I always walk, going to and fro the shop and so on. But when I move further away, I always have to be very careful to remember how I came there so I can get back. I have more and more problems finding people's names because I can't replace them with anything else. When I don't find a word, I can always replace it with another one. But that's annoying, not knowing people's names, or perhaps also recognizing them. So the more I tell people about having dementia, the more understanding I encounter, and the more comfortable is my life with dementia. And I realize how many people around me actually have questions and would be interested to find out more about the risks and about the science of an early dementia. I think we should do more as Alzheimer's associations, and I think we should also try to reach out to the doctors, to the general practitioners, to get them more conscious about the science of dementia, because it's nothing dangerous to have a diagnosis. It doesn't get worse. On the contrary, you can have some kind of help, and it's not annoying to talk about what's happening to you. I don't find it annoying at all. I find, on the contrary, that I get very good response. So that's my message, I think, as a person with dementia.
Thank you very much, Birgitta, for your intervention. As ever, very poignant, quite a lot of comments on it in our various channels of communication. And I'm sure quite a few people will want to pick it up later. I have seen that we have quite a lot in the question. Can I remind people, if they want to introduce themselves or post resources, please do it in the chat, not in the Q&A, because you make my job of managing the Q&A later harder. But you're very welcome to share resources. It's been a very interesting conversation happening whilst our speakers are talking. Now, I would like to introduce you to our next speaker, who is Dr. Grazia Dell'Agnello in International Medical Affairs at Eli Lilly. Now, we have asked the two companies that are looking at therapeutic breakthroughs to come and talk at this webinar, but their intervention is going to be around the issues of diagnosis and of post-diagnostic support. We always make a point at ADI that diagnosis has to be timely. There are some comments in the Q&A, and we'll pick them up later, about uncertainty of diagnosis as well. So there are a lot of issues around the issue of diagnosis, and a lot of issues around the issues about how to support people after it. So I'm going to ask Dr. Dell'Agnello to take the floor, and after that, Dr. De Santi, to give us their perspective of the diagnostic debate. Thank you so much, Grazia. The floor is yours.
Thank you very much for this kind introduction and for inviting me to this webinar. And hello, everybody, wherever you are following us. As said, my speech today is mainly to share with you how the arrival of the new treatments, and especially the amyloid targeting therapies, will change the approach to Alzheimer's disease management, and how we can work together as many stakeholders to facilitate the evolution of the care pathway for the people with Alzheimer's disease. And then if we think about the care pathway, for sure, the first step in the care pathway is that of diagnosis patients. And we have to consider how the new treatments have been studied in the clinical trials with a focus on the early symptomatic Alzheimer's disease patients. So patients that are at the earlier stage of the Alzheimer's disease, presenting symptoms. And the involvement in of this patient in the studies went through the clinical assessment of them, which was coupled with also the biomarker assessment in order to confirm the presence of amyloid and tau pathology, so of Alzheimer's pathology. And in order to have this accurate diagnosis and of early symptomatic Alzheimer's disease and the appropriate identification of patients who may benefit from upcoming amyloid targeting treatments, this will require a paradigm shift from how Alzheimer's disease is considered now as a clinical pathological entity by the majority of physicians to Alzheimer's disease as a clinical biological construct. But what does it mean in practice? It means that currently diagnosis and treatment are mainly based on symptoms, which has limitations and consequences of patients being diagnosed too late when they are already moderately demented in many cases and are also misdiagnosed. So we need to evolve from this situation and diagnose patients combining the clinical characteristics together with the use of biomarkers to confirm Alzheimer's pathology in vivo, and also the treatment initiation will be guided by biomarker assessment, because we know that with biomarkers like CSF or PET, we can improve the accuracy in the diagnosis, as well as we can improve the confidence of physicians in diagnosing patients. And even more important, the use of biomarkers can have an impact in the treatment decisions, as we know, for example, from a big study which was conducted in the US, the IDEA study, in which more than 60% of the patients with MCI or dementia have their management changed after their physicians received the results of the amyloid PET. I'm sorry. Okay, good. So diagnosis patients combining both clinical and biomarkers analysis will also allow what was before mentioned by previous speakers to have a more personalized approach to treatment. And here I'm just talking about the pharmacological treatment. And if I think about the care pathway, the most or the biggest improvement in the care pathway could be to the possibility of using disease modifiers, which are designed in order to target and act on the underlying disease pathophysiology with the aim of impact the disease trajectory. As you can see, for example, here in this model for illustrative purposes, with the delay in disease progression of the disease modifiers respect to non-treated patients, or also patients that are treated with symptomatic medications. So if we go on with the treatment pathway, it's important to consider then the efficacy of this new medication, the evidence of the drug efficacy, as well as the monitoring of the treatment response, and potentially also the treatment duration, which should be evaluated for sure using the clinical assessment, but may be also supported by the use of biomarkers. And this is what we did, for example, in our Trailblazer ALZ phase 2 study, in which, of course, as you can see in the left part of the slide, we assessed the efficacy of donanemab using clinical outcomes, in particular the integrated Alzheimer's disease rating scale, showing a 32% slowing by donanemab at the end of the treatment period versus placebo, but also evaluated the biomarkers outcomes. Even in this case, showing a superiority of donanemab versus placebo in reducing the amyloid burden measured through the floor beta peer PET, and observing 60% of the donanemab treated patients that reached amyloid clearance level at 52 weeks. What does it mean? It means that the biomarkers will be helpful for monitoring the treatment response, and also potentially for monitoring the treatment duration, especially if we think, for example, for donanemab, that we have used the stopping rules based on amyloid clearance at specific time points during the phase 2 study. And if hopefully donanemab will be available in clinical practice, these stopping rules potentially can be used also in clinical practice. Finally, what I wanted to say is that an additional part of the monitoring for the treatment will be related to the, sorry, I'm not able to move to advance the slide, but what I wanted to say is related to safety. Safety monitoring, here I'm talking specifically of amyloid-related imaging abnormalities that are the most common side effects observed with amyloid targeting monoclonal antibodies. And we know that in the majority of the cases, these areas are asymptomatic. And in the clinical trials with all the amyloid targeting treatments, the monitoring of area was based on the use of magnetic resonance at baseline and during the regular monitoring in the clinical trial. So we could expect that treatment modification and stopping rules based on area monitoring will be also defined in clinical practice when this medication will be available. So, as said, many different changes in the care pathway for patients with Alzheimer's disease, from the diagnosis to going on through the treatment. And in order to allow the optimal use of the new treatments, specifically the amyloid targeting treatments, if we can go to the next slide, we need to have a joint effort from the different stakeholders.
Grazia, sorry to interrupt you. You will have to wrap up because we are over the time.
This is the last one. Definitely a joint effort, which means that we need to implement education for physicians to consistently enable the timely and accurate diagnosis of Alzheimer's disease, and we need to educate them on how to use appropriately the amyloid targeting treatments. But of course, the healthcare system should be prepared for that, which means that we need to enhance its infrastructure to support all the steps of the diagnostic and the treatment pathway. We'd also work on scalable diagnostic. For example, this is an engagement that Lilly has to work on blood biomarkers that can help more patients to initiate the treatment through and monitoring the treatment effect. In addition to that, we need to create infusion facilities and also think about services alternative to having the patients going to the hospital for taking the medication, like, for example, nursing. And finally, we need to ensure diagnostic and treatment resources. And when I talk about that, I'm not talking only about the Western country, but I'm talking about the global effort that should be implemented with the joint collaboration of all the stakeholders. Thank you very much for your attention.
Thank you, Grazia. I will move quickly to Susan. I thank you for your intervention. Can I remind speakers to stick to their times? We've got a huge amount of questions in the chat line, and I really would like to be able to ask some of them. To those of you who are asking whether the slides are going to be available, the webinar is going to be posted within 24 hours on YouTube, so you will be able to watch it again at leisure and look at the slides in your time. Thanks so much, Susan, the floor is yours.
Thank you. Thank you, Paola and ADI, for inviting us to participate in this panel discussion. So by way of disclosures, I'd like to say that I'm a full-time employee of Eisai, but the statements that I make today during the discussion are really my own opinions and not those of Eisai. So when we consider how AD treatment, the treatment world is changing, the pharmacological treatment options for those with AD mostly address the symptoms using cholinergic and glutamatergic modulators. And these treatments were approved more than 2 decades ago to address cognitive and behavioral symptoms. And other types of treatments, like Pedro had mentioned before, specifically those non-pharmacological interventions that have the promise of preventing or delaying cognitive decline. For example, the finger study used multi-domain approaches including nutritional guidance, exercise, cognitive training, social activities. They also talk and manage the vascular risk factors as well as the metabolic risk factors as a way of, which are the associated increased risks for AD. And these treatments go hand in hand with the diagnostic paradigms that have largely been used in clinical practice, namely assessing the clinical features and the presenting symptoms, including cognitive decline, behavioral symptoms, functional decline, where cognitive testing remains the foundation of the clinical diagnosis and the staging of patients with AD. But now that this new wave of pharmacological compounds that are targeting the pathophysiology and the hallmarks of Alzheimer's disease have reached late-stage clinical development, with one compound being approved by the FDA already for clinical use in AD. And these emerging treatments aim to maintain cognition and function, thus potentially allowing the individual to function at a higher level longer. These individuals have early stage AD, including mild cognitive impairment that's due to AD, and early and mild Alzheimer's disease. And these are the targets for these treatments, and they hold the possibility to alter the clinical progression for these patients. The increased inclusion and focus on patients that are milder stages of the disease, including those that are younger, maybe more functional, less vulnerable, is really a shift from the current state. And those needs and expectations for AD clinical care may be very different from those that are at a more severe and advanced stage of the disease. So these new treatments call for a change to the clinical care and diagnostic pathway, and the incorporation of biomarkers to support the screening, the diagnosis, the treatment, including treatment monitoring and treatment decision-making. Establish A-beta markers, such as those that are measured by PET imaging or CSF analysis, assess the presence of amyloid pathology, and they'll most likely need to be incorporated into the diagnostic pathway for these new emerging treatments. Tau markers and other markers of neurodegeneration are important for the in vivo diagnosis of AD. And the identification of other co-pathologies is also important, because that will help us identify those that we think will be responders and non-responders to these new treatments. In addition, the development of blood-based biomarkers in AD is rapidly advancing, and that serves an unmet need in the diagnosis and management of AD, given their broad availability, their scalability, and their cost effectiveness. However, there are still lots of hurdles that have to be overcome at the scientific, the regulatory, the healthcare infrastructure levels in order for these blood-based biomarkers to become widely incorporated into routine clinical care. So in addition, there are digital markers and digital health technologies, including digital cognitive assessments that are emerging, and they have the promise also to be assisting the AD clinical care and the potential to detect early cognitive decline and to monitor disease progression. However, the barriers for early detection and timely detection, as well as early intervention, still exist in routine clinical care. And we hope that the early signs of AD may be better understood by the patient and the family member, and that there'll be less stigma around the diagnosis. The clinician and patient need to recognize the importance of early detection and diagnosis and not overlook the early symptoms and mislabel them as normal aging and early treatments. So the diagnosis world is changing, and we're transitioning from the clinical symptom-focused paradigm where AD is often detected at a mild to moderate stage of AD to a biomarker-guided and digitally facilitated clinical care pathway that focuses on early detection and intervention. And these early treatments are targeting disease pathophysiology and to potentially change the clinical trajectory. And this is a radical difference from the previous pharmacological treatments. And they will require, they will be something new for physicians, and there will be a large learning curve for physicians in terms of how to best guide and help their patients and their families to navigate this journey across the disease management. Both physicians and patients will need to develop a mutual understanding for the expectation and the actualization of the disease attenuation with these new treatments. Thank you.
Thank you very much, Susan. Quite a few people asked whether you had slides. Just to confirm, Susan was speaking without slides, so it's correct, you didn't miss anything. Thank you for a very interesting and quite insightful intervention. Because we are running a little bit over time, I'm going now to ask Yuda Turana of the Atma Jaya Catholic University of Indonesia. Dr. Turana will talk about his viewpoint, especially from a middle-income country, of the results of the report. Yuda, the floor is yours. Thank you for being with us.
Yeah, thank you, Paola, for the nice introduction. Good morning, good afternoon to everyone. Great honor to join this meeting. So I think the World Alzheimer Report in 2022 was a comprehensive references for a lot of insightful information. But in the brief, I will highlight maybe the important variables, especially for the low middle income countries, like increasing awareness in reducing stigma, the accuracy of the diagnosis and long-term care. I think this the very important one. And of course, with the approach comprehensive, involving not only the health workers, but also the family caregivers, Alzheimer Association, and also the government. So about the reducing stigma, like we already know in the low middle income countries that still thinking a lot of the community, the caregivers still think about the forgetfulness is part of normal aging, and also in the health workers that the stigma about the nothing we can do with the disease. This will indicate the lengthy time taken before being given a diagnosis, and the stigma will make the situation also make the elderly that come to the health facilities not because of the dementia, but because of the other disease, and not focus on the dementia, and dementia not become the priority of the treatment. And also about the increasing diagnosis accuracy rates are important, but need to occur alongside with developing support and the care pathways. And the other variable that also important in strengthening post-diagnosis support in low-middle income countries is long-term care. I think the health services in low-middle income countries, especially in our countries, will focus on services, especially in the clinics, in hospital, not in the home visit or in the community. So I think in the era of the pandemic and the post-pandemic, I think we must build strengthening the long-term care, the community-based home visit, teleconsultation, that including increasing competency of the caregiver, family caregiver in care of the their person in dementia. So I think strengthening the long-term care, I think will become the policies at the national level, that national level must support this, and hope the long-term care is become a part of the basis of the health services for other people, especially for frailty and person with dementia. I think that's it, Paola. My brief, the highlight, the important thing about several things: reducing the stigma, increasing the diagnosis accuracy, that in line with alongside with developing support and care pathways, and strengthening the long-term care, and need the national policy or policy at national level that make the LTC become basic health services for the older people, especially for person with dementia. Thank you, Paola.
Thank you so much, Yuda. And coming from Indonesia, where there's been so much happening also during COVID-19 to support people with the diagnosis and to keep people moving. And that was something that we talked about in one other of our webinars. Now, the time for presentation is over. I would like now to focus on an incredible Q&A. We've had some really great questions. I invite all the panelists to raise their hand if they want me to include them in the conversation, but I will ask a question now to start with to Professor Pedro Rosa-Neto. Pedro, there's a great question here from Nathaniel Welch. Besides funding, where do you see the greatest room for improvement in post-diagnostic care for dementia patients, either from a medical or a policy perspective? Pedro.
I think for the most important aspect here is, I think, is education. I think people have to be properly informed regarding actually how to manage patients with dementia. But for me, I think it's important also to make sure that the patient has a proper counseling and the family has the proper counseling and the care partner as well. I think information is the most important aspect. I think the medication also plays a very important role, but it's important to give to the individuals affected by the disease and the family members the perspective, what is next and how to prepare for the future. I think the education in this process comes first. Education is important for the medical professionals. Education is important for the patient. Education is important for the family.
Thank you very much. Not having seen any other hands go up, I'd like to move and ask José to answer the next one. It's a great question from Peter Whitehouse that also refers back to the diagnostic report of 2021. Did you consider post-diagnostic care when the diagnosis is uncertain, unclear, or turns out to be wrong? Last year in the diagnosis report, we stated very clearly that up to 20% of all diagnoses are not correct. How much humility, continues Peter, should diagnosticians show in face of the complexity and uncertainty surrounding, for example, the utility of biomarkers? Should we be more careful about keeping research, volunteering, and clinical care patient-client separate? That's for you, José.
Yes. Well, this is an important and interesting question that has many aspects to it. But we addressed this indeed in the report 2021, in which we said that if we are not sure about the diagnosis, we have to be honest and tell the person and the caregiver that the diagnosis still uncertain, and we need further assessments, a few follow-up visits in order to reach an understanding of what is the etiology of the cognitive deficits. You know, we order blood tests and imaging, and only after that we can increase our certainty. So yes, it's true, we need to be humble facing a disease that has many facets and impact on lives of patients, and it is the right approach, not precipitate the diagnosis until we are more sure of it. This is especially true in the early stages, because there is an overlap of symptoms and signs, etc. But eventually it becomes more certain, and we have the obligation to tell the patient by then, if it is the case, so that the person will then take measures to make her life according to her or his wishes.
Thank you very much. And again, I suggest all of you interested in this, there is a big chapter in the report 2021 on this very question. And also there is a lot in both reports around the compassion and the lack of arrogance that needs to be displayed by the diagnosing clinician. I think everybody acknowledges here that there's still so much we don't know about this disease. the really absolutes are very difficult to dish out. And with this in mind, I'd like Birgitta Martensson first to comment on this, and I, Pedro, Susan, and Grazia perhaps to come in on this one, which is really interesting. There is a lot in the report about staging of the disease. This is a question from Hong Yu, and he says, it is a big question puzzling me whether we are over-diagnosis of dementia. Should we only diagnose late dementia and dementia and label others as mild and moderate cognitive impairment? Now, I was having a really good discussion with someone else about this very topic. I think this is going to become a big issue, especially in the next couple of years. So, Birgitta first, what is your feeling about the staging of the diagnosis as a person that now is living with Alzheimer's? And then Pedro and Grazia and Susan, if you want to come into this one. Thank you. Oh, Birgitta, maybe we have lost you, in which case can I ask Pedro to go first?
Yes, I think this is extremely important because the question when you're talking about this chronic and progressive diseases, what comes next? So people, they will have the conditions to plan, the conditions to prepare themselves psychologically and to prepare the need of upcoming intervention. So knowledge allows us to make choices. So therefore, framing the disease in the kind of a progressive stage, I think it's very important. For medications, for example, the medications available, they're indicated to early stages and more advanced stages of the disease. Neuropsychiatric interventions, people, they have to be prepared to handle them. And these are characteristics of more late stage of the disease. I think this stage guides therapy, and the stage also guides, prepare people for what's to come.
Thank you very much. Grazie, Susan. Do you want to, because there is a relevance to this.
Yes, definitely there is a relevance also for the clinical research, the clinical trials. And I think that staging will continue to be relevant for including the appropriate patients in the clinical trials. We have many examples from the past for which patients that were included in the trials when they were already to a more advanced stage were not didn't receive the benefit as expected. Now with the clinical trials, with the new medication, an appropriate selection of the patient, which was also based on the staging, is start showing a positive result. So I think that staging, framing towards the staging, as said, is important to plan. And among the plans for the patient, this could be also to plan to be involved in a clinical trial.
Thank you so much. Susan, do you want to come into
Sure.
that?
Yeah, thanks. And I agree with Graziella because there are the clinical trials really have been so important, really studying patients at the earlier stages. And even at the preclinical stages, there's a number of studies that are going on currently. So I think being able to identify and stage people and put them in the right trial is really important. So ultimately, I think the goal is the right patient for the right treatment at the right time, and that they would have the benefit with that kind of structure.
Thank you so much. I mean, this is a big question and a big issue, especially in view of what is to come. Again, we dealt a lot about this in last year's report on diagnosis. Now, I see that Birgitta is with us. Birgitta, I hope you can hear me. I've got a question for you, but perhaps not. Well, I am therefore going to go for a question for Yuda. Yuda, there is Birgitta is back with us. Great.
Yes.
Birgitta, fabulous. There is a question that I would like to ask you. One of the attendees is asking whether we can talk more about the role of peer support for those recently diagnosed and scalable models for providing these. For example, an encouraging letter from advocates living with dementia that doctors can give to their patients when making a diagnosis. Now, we have been talking a lot about this in the report. There is a lot of information available. Our members provide it, and you were CEO of Alzheimer Switzerland, but often doctors at primary care level don't receive it. So with your hat as a person living with dementia and as a former CEO of an Alzheimer association, can you give us your views on this question? And you need to unmute yourself. And I think we have issues with the audio. So I'm going to go back to...
Oh, here.
Oh, Birgitta, there you are.
Here I am. So the question is?
So the question is...
Very short.
Yeah. Can you talk about the role of peer support for those recently diagnosed and scalable models for providing peer support? For example, an encouraging letter from an advocate that is living with dementia the doctor can give to a patient when making a diagnosis.
Yes, I think people with dementia can do a lot for their friends in the sickness. If it could be the doctor who could ask the patient, are you ready to take up a contact with another person? That would be a very good idea. You could also tell them when you go to the pharmacy, for instance, and perhaps also pick up contact with the Alzheimer Association in your country or in your region to tell them that I have a diagnosis and I'm ready to be there to talk to other people who live with dementia, or perhaps even people who think they have dementia. I think that's something that could be very useful, because you could take away a lot of frightenness from these people who feel that, I don't dare, I don't want to. Is that an answer to your question?
Yeah, completely. And just to remind everybody, we try very hard at ADI to make sure that governments understand the information is available. The whole point of having the report was to make sure that governments will give information to people. But that is still very difficult at primary healthcare level. A lot of doctors still have stigma, as Yuda said. A lot of people still don't diagnose and they don't want to talk about it. I'll move on very quickly. There's a great question from Hilary Doxford. In clinical trials where the majority of patients respond to the drug treatment, this is for Susan or Grazia, do the researcher companies analyze the characteristic of those patients who did not respond to possibly identify misdiagnosis or understand other patient characteristics which suggest the drug will not be beneficial for a specific patient group? Now, I also have a question for Yuda, so can I ask you to reply to this really quickly? Thank you.
So maybe I'll go first and say, yes, we do. In every clinical trial, we look at what's positive, and then we look at what's not positive, and we try to understand if there were some certain features of a patient group for the non-responders, so that we could better identify those who should be in the next clinical trial.
Exactly the same from my side.
Susan. Do you want to respond, Susan?
Oh, I did respond.
Sorry, yeah. Oh, sorry. I've got somehow things moved out in my screen. Sorry about this. Yuda, okay. What are some of the commonalities and differences post-diagnostic support service should entail in different cultural background? I think this is a really good one for you. What are some of the commonalities and difference post-diagnostic support service should entail in a different cultural background? How are you finding it from your side?
Yeah. Thank you, Paula. I think in experience in Indonesia, I think almost the same in other low middle income countries, that we have the problem when in the early stage, usually they say that the problem of the memory as a part of normal aging. But after in the late stage, the people thinks that, oh, this is very hard, is no cure about this. So this is, I think, to different side of the stigma that make the person with dementia not come to the health services, that it's become a normal part of aging. But if already diagnosis and said this is dementia, disease is very severe disease. Is no cure for this. I think this to kind of the stigma that make the services is not effective.
Thank you very much for tackling that. That's very complex, and obviously there are questions for every cultural background. Again, I refer you to the report. There is a lot in the report around that. Now, a question briefly for Jose is a simple question from John Zeitel, who is one of the authors of our 2020 report on design, dignity, and dementia, that speaks about a design and how that can be employed very effectively as a psychosocial intervention in itself. But his question, which is a simple question, is not simple at all. What specific non-pharmacological eco-psychosocial programs, not treatments, do the authors support to improve the post-diagnostic quality of life and well-being of people living with dementia beyond the general concepts of diet, exercise, sleep, and so on? Jose, would you like to tackle that as quickly as you can?
Yes, I mean, this is a difficult question. I think that we have to learn to communicate information and what the person living with dementia, and also discuss when it's possible what are the interests of this person. This is a true empathic and respectful way of dealing with the person living with dementia. You know, but there is a lot of challenges, especially when a person understanding is reduced, and due to stress, anxiety, then there is the difficulty in accepting what is being proposed, etc. A lot of compassion is needed at this level, at that moment, and in particular, I think we have to grasp that you know, it is our responsibility to adapt to that person rather than expecting them to react in a fully normal way. So you know, again, empathy, listening, having the right humane qualities will facilitate a lot the care and you know, the well-being of the person. Yeah.
Thank you very much. Very, very briefly, this is a question that is occupying our mind at ADI. Grazia, could you come on to this one, which is how can lower and middle income countries also have access to clinical trials? This is a big issue, just raised it in Lausanne last week. Do you have any opinion on that briefly?
Yes, I fully agree that this should be the case. We have implemented our trials for now in high-income countries mainly, but we are working through collaborative consortia, like for example the Davos collaborative consortia, even in lower countries. And if it's not for implementing clinical trials, it's at least to improve the pathway of the patients also in the low-income countries.
Lovely, thanks, Grazia. The last word to Pedro. Pedro, really good question here. How would post-diagnostic support be different for persons who are diagnosed with young onset dementia versus non-young onset dementia, please?
So this is a very important question because it's very different. So when you take into consideration the cultural, the social aspects, so young onset dementia, usually patients, they have young wives, they have young children, and these children need support, and they would like to communicate with individuals with the same type of problem, not individuals with late onset dementia. I think we have to raise awareness to the fact that patients of early onset dementia, they require special care, and also in terms of clinical trials, there is the need to include these individuals for such new pharmacological interventions. So they're very different, at least in my perspective, and they deserve to be treated with more dignity and inclusiveness.
Thank you so much, Pedro. This is all we have for today. There were a number of really fabulous questions, one about collaboration, for example, and a center to study this more fully, which I hope will give our speakers further food for thought, and perhaps you can get in touch with the people that ask those questions. All that is left for me to say is to thank you all very much for participating. Thank again my wonderful team. I'm never alone when I do these webinars, and in particular Katie Bingham and Jane Ciborra that have been with me today, with Isabella MacLeod helping me and supporting me through this. Thank all of our great panelists for their focus. Forgive us all if we are so quick in these webinars, but we know that we better take out as many concepts as possible and leave you with a lot of food for thought. You can read a lot more in the report. I remind you as ever that you can follow what we do at ADI. There is a lot more on our website and in all the information that we put out every day for you to read and digest. We thank you very much for being with us. There were over 73 countries in this webinar. Thank you for making our gathering so colorful and so interesting from so many different viewpoints. Thank you again, and I will look forward to seeing you at our next webinar that we will announce very soon. All the best and have a lovely day. Goodbye.
Thanks, everyone. Bye.